Hi, so my name is Mary Tipton. Hope you bear with me during this presentation because I've never done anything like this before, especially not in my bedroom. But what I wanted to do is just get a video out as quickly as I could to try to help our teachers and our parents who are so worried about sending their children back to school. We know that's happening in just about a month, and a lot of people are so worried about it. And so I was just hoping as a pediatrician and a mom that I could provide a voice of reason and facts and just encourage us with the information that we have that I think leads to the decision that not only should we reopen schools, that we must reopen our schools. So welcome to Coronavirus Conundrum. Can we get our kids back to school and keep our teachers safe? So as I mentioned, my name is Mary Tipton. I'm a physician, also an owner at Copperview Medical Center. And I've been there for a long time, like 14 years. I've actually lived in West Jordan for 13, and I'm a mother of 4 children. All 4 of my children in the Jordan School District. I have ages from 6 all the way up to 16. So yes, I had a kindergartner and all the high schooler and 2 in elementary during our spring experiment of closing schools and online, and it really was tough. So I know how it is to be a working mom and to have our children doing remote learning versus being in school. I do work full-time, more than full-time, and so I am so grateful and forever indebted to our teachers. I could not do this without them, and if there was ever any doubt after the spring, we know we need our teachers and we need them to be in our children's lives. They can motivate and encourage our children in a different way than any parent can, I believe, at least for my situation and most parents. So just because I don't know how far and wide this video might go, I wanted to tell you my education so you know I'm not just making some things up. So I want to tell you that I grew up in Anchorage, Alaska. I was in the public school system for all my education. Actually skipped kindergarten, so I should have put that it was 1st through 12th. But I had a great experience in public schools, went to a state school in Arizona for chemical engineering, graduated summa cum laude with a bachelor's in science, and then went on to medical school at University of Utah. And since I graduated from there as a doctor, it's been 21 years now. First did my residency training in Dayton, Ohio. I did what's called a double residency. So it was longer, almost 5 years. I did internal medicine and pediatrics. So I'm actually board certified for both of those things. And I work at 3 different hospitals locally. I work at Riverton Hospital, Lone Peak Hospital, and Jordan Valley Hospitals. And I've been a primary care physician for 19 years. So I feel that all of these things help me to really know what we're dealing with here. I'm a frontline worker, I'm an essential worker, and I'm also a mom, and all of us moms are basically frontline workers. We've got to focus on what our real enemy is. So this talk will be divided up into 4 different topics. So we have, see, I can use my handy pointer here. So we have our first thing, number 1 is just the enemy. This is the virus. This is not other people. This is not belief systems or certain politic groups. It's just the virus. We didn't have any of these problems like as severe before the virus, but boy, has it amplified some of our underlying problems, yes. But SARS coronavirus, or SARS-CoV-2, as we call it, is a novel coronavirus. And we're going to talk about the methods and consequences of infection with that virus. And yes, it's all scary. I just wanted to tell you, when March hit, I was scared. I had many sleepless nights. I was afraid for my children. I was afraid to run my business. I was afraid economically. I was afraid that for so many unknowns. And I want to tell you that I think we're in a much better situation now. So although I had to redesign and go to work in March, April, May, June, July, it's awesome that we took a pause. Because now going back to school, we have a lot more tools and information at our disposal than we did in March. Number 2, we're going to talk about mitigation strategies. We do have some tools and education and information and data, like I said, now to fight this enemy. And we, I think, can successfully use them to reopen our schools. Third is why I think this is important. Again, as a pediatrician and primary care physician, I've seen firsthand the havoc and suffering that coronavirus has brought onto all of our families and everyone. And it's crazy to think that everyone in the world has suffered from this, but it's true. So if people haven't been infected by the virus, they've been affected. If they haven't been infected, they've been affected in some way. And finally, I just want to reiterate that unlike what I also thought maybe in May or March, that we would just kind of be able to wrap this up and go back to normal, it's increasingly clear that that is not the case. And we need to find a way to live with this virus for the long haul. So thanks for bearing with me again, and we'll get this started. I think it'll be about 30 minutes. So viruses, they don't care so much who you are, what you look like, what's going on. They just want to replicate. They're just a little tiny bit of DNA or RNA in this case, and they want to replicate and just find another host before they die. So we don't have a cure. We don't even have strongly effective treatments, and we definitely don't have a vaccine yet. So the only tools that we have is to block the transmission of that virus. And that is what I'm going to be talking about today. COVID-19 is actually not the name for the virus. COVID-19 is the disease that's caused by the novel coronavirus. You see underlined here, coronavirus. That's because coronavirus is not new. We've had coronaviruses that we've been finding and treating in our patients for years. They usually just cause things like the common cold, but this is a novel coronavirus. And so that's why it's named SARS-CoV-2, SARS, because it's similar to some previous respiratory outbreaks that we've had. This one originated, we know, in Wuhan, China. We don't know exactly how, but it was in December that it was first identified. And again, it's novel. So that's why we don't know everything, but we are learning things. And so I hope to provide the most updated information that we have as of today, and that is the 20th of July. This could change. A lot of things have changed and will continue to change, but to my knowledge, this is the most updated data as of today. So as mentioned, the transmission of this virus is by speaking. So it is respiratory droplets, it is singing, it could also be screaming, any sort of shared breathing. These respiratory droplets can come from our nose or our mouth essentially, but they can enter all of these orifices, so our eyes, nose, and mouth. And we believe that larger droplets, and we know this from other viruses, larger droplets are more infective because they carry more virus particles, and the more load that you are hit with, the more likely you could be infected. But we also know that it can also be transmitted in tiny aerosolized viruses, in tiny aerosolized droplets. So when you hear like it's airborne, okay, yes, it is sometimes airborne, but that is not the primary method of transmission, small droplets, because it's less likely for them to infect us. They're just smaller, they contain less virus, but it is a possibility. So depending on how likely it is to have aerosolized virus in your vicinity, you might have different protection than large droplets. But we believe that larger droplets and at a closer range are the more likely method of transmission. Symptoms are really varied. I hope you can see this chart that I copied from the Salt Lake County Health Department. I think it's interesting to note that most people have cough, but not 100%. This number right here is only 57%. That means we have 40-some% of people that do not have a cough and they have coronavirus. Looking down here at fever, people might ask, is checking a temperature important? It's not a great differentiator. Many people have chills, but that's only 36%, and 33% only have fever. So that means a majority of people present and have an entire sickness course with coronavirus without a fever. So that's why fever is no longer used in the hospital settings in our local community, for example, to screen visitors, because I think it maybe made people feel better, like we're doing something, but it's not a universal sign or symptom. There are some gastrointestinal symptoms. At the bottom here, there's diarrhea, nausea, vomiting. We hear about those, but you see these are lower, 11 to 25%. So majority of people I've seen, they do have cough, muscle aches, and headache. Loss of taste and smell are very specific, but not very sensitive, meaning there are other reasons to develop a loss of taste or smell, but if people do have that and some of these other symptoms, that can be very helpful to identify coronavirus. Some of the good news is that we found that there is actually minimal transmission by fomites. We use the word fomites to describe like surfaces, table, doorknobs and stuff. So you'll see a lot of paranoia or time spent cleaning surfaces. It's important to a certain extent, but I believe in our schools, there's areas that are probably more important to focus on, maybe even in our homes. So yes, we should clean things, but it's not the primary method of transmission. So masks, for example, that prevent the shared breathing or droplet transmission is much higher yield than like washing a bathroom every hour, for example, which could take a lot of staff and time. So we believe there's minimal transmission by surfaces, and that the virus, can be killed on those surfaces relatively easily with cleaning solutions, sometimes light or heat. Finally, I think it's important to realize that the virus enters our respiratory tract by binding some of these crown or corona-shaped proteins that are on the surface of the virus that you can see here, bind with the ACE2 receptors. These are found in our respiratory epithelium, so they're found in the nose and mouth. And as I'll show you in a minute, the different levels of ACE2 receptors we think affect why or result in different rates of infection between children and adults. So are children affected by coronavirus? For sure, they can be, but they are not very often. So again, this is current cumulative data for hospitalizations for the entire pandemic in the Salt Lake County. There have been very, very few hospital admissions. If you look at, like, for example, our elementary school age kids, this 0 to 9, 10 to 19 group, there's just very, very few, hospitalizations compared to those in older people. Definitely the older people are hospitalized more, and as we'll show in the next slide, they also are more likely to die. So over here we see that very few, just one child under the age of 40, the entire pandemic in Salt Lake County has died. And as you might know from some of the press coverage, it can be hard to differentiate the cause of death. If you just have one or very few deaths, you might really need to kind of wonder, what other comorbidities or situations would have been present. I mean, clearly, if it was common for young children to die of coronavirus, there would be more than one, and that was actually a young adult or 20 to 29-year-old there. So children just are not infected very often. When they are infected, they are less likely to be hospitalized and much less likely to die. Back to that discussion I had earlier about the ACE inhibitor expression in young children. So a study was done pretty recently by a group that has been studying this in the setting of asthma. And so they, I think, already had been working on it. They actually did nasal biopsies in hundreds of people, all ages, children up to adults. And we found that in children less than 10, they have a much lower level of ACE2 receptors in their nose. Now, I'd like you to note this is a logarithmic scale. So 2.25 is vastly different from 2.75 and 3 and 3.25 by magnitudes of 10. So young children less than 10 have much lower ability to bind that coronavirus in their nose, we believe. And that's why some of the findings we have and differences between children 0 to 10 and 10 and up and above exist, we believe. So these implications obviously vary according to our elementary age kids who are here and our middle school, maybe here, and high school. But you will see that by 18 or somewhere between middle school and high school, these teenagers acquire an relatively similar, almost equal levels as adults. So that's why the recommendations do change from younger perhaps to older as far as how strict we need to use mitigation strategies. Exposure risk is not an all or nothing thing. There's been lots of jokes and memes about like, oh, stay back 6 feet, six is the magic number. It's actually a made up number. That is true in some circumstances, but not all. So like most things that we like to just grab onto, it is just a number that we think may apply sometimes. The exposure risk is a gradient. It's a function of time and dose. So we believe that the larger droplets, the longer amount of time, the closer proximity equals higher exposure risk. And conversely, if we are only being exposed to aerosolized droplets for maybe shorter periods of time and at some distance, whether that's 3, as it is in most European countries, by the way, for schools, the World Health Organization recommends 3 feet as a reasonable distance or a target distance for younger children. That distance helps. The further the better, but you know, there's a balance between what's reasonable. And again, there's lots of variations. So like I said, why is 6 not always the magic number? Well, it depends on whether the person is masked. It depends whether there's good ventilation. It depends if you're indoors. It depends if you're outdoors. It depends if you're coughing, vomiting, spitting, or just breathing quietly. So we need to keep that in mind as we consider our mitigation strategies. They're not always going to be textbook to the number, but maybe they are adequate. We don't know, but we believe that one of the reasons children also have less likelihood to spread or get coronavirus is that they have smaller lungs. And because they're not very symptomatic, maybe they don't cough as much, they can't cough as far. So that 6 feet distance, you know, which may apply for adults in certain circumstances, may not apply to children. We do, though, believe that when you get to a certain age, and probably many pubertal teenagers are more equivalent to adults in their ability to spread and get coronavirus. Sorry. Oh dear. Okay, so children are basically not super spreaders. So this, I understand, is a novel concept, and it's very strange to teachers and maybe to pediatricians as well, because we know that they spread RSV. We know that they spread hand, foot, and mouth disease. We know that influenza outbreaks are rampant in our schools and maybe daycare centers, but for some reason, SARS is different. SARS-CoV-2 is different epidemiologically that way. And how do we know? Briefly, just a little bit of data. The contact tracing studies worldwide shows that the index case, so this is where they find out, you know, Susie had it, married to Bob, 3 kids in the house, and they go back, you know, where did they go to work? Contact tracing has shown that the index case is very rarely a child. So it did not start with a child. It's usually less than 5%. Sometimes it was like 1 to 2. In some studies where there's higher community spread, it's up to like 7 or 8. But generally, it's just not a major part of the children are not a major part of the what we call the index case, or the person who started the outbreak. And you might be interested to know that even adult household contacts. So we always think like, if it comes in our house, everyone's going to get it. Well, actually, no. I mean, most households and all the contact tracing around the world have shown that maybe spouses living in the same bed and bedroom have a 45-ish% chance of getting it. But all the other family members have less, maybe 10 to 20%, and children in houses with active coronavirus cases had only a 4% chance of contracting it. So even when they're exposed, close proximity by family members, children are not getting coronavirus at a high rate. And I must say, it's never been proven actually that a child was a transmitter of coronavirus. These are just retrospective cases. So the theory is that perhaps in some of these cases where they presumed or thought that the index case maybe was a child, there could have been another asymptomatic adult that had given it to that child. They just weren't able to identify him, because in no prospective trials had they found a child that has proven ever to transmit coronavirus to another child or even an adult. That's very significant. So teachers should take some real confidence, I think, in that in this case, in coronavirus specifically, children are not super spreaders. So transmission is exceedingly small, but again, sorry, you who teach high school and maybe middle school, we know that the transmission rate and infection rate for coronavirus is higher in older children. We're not sure how high, but at some point, obviously, it approaches the adult levels. Another source of information about Another source of information comes from countries who have reopened their schools. You may not know that at least 27 countries, perhaps more, many in Europe and other Asian countries, have had schools open for many months. And in those countries, schools have not been found to be the source of outbreaks worldwide. Some of our data is even shutdowns before or during outbreaks, and then also reopenings, but schools have just not been shown to really be the epicenter of outbreaks. So yes, all these schools have some restrictions in place. You might be interested to know that many of them do not require masks, and their guidelines are not 6 feet, but 3. I'd like you to look at this graph if you can. So on the dashed line here shows that schools reopened on this date, and you can kind of see that all the countries, you know, who reopened after the peak in their country, like United Kingdom, Germany, France, etc., had continued declines. There is a couple going up, Madagascar, Vietnam, and we have to be careful not to make too many assumptions. There's so many variables here. Other changes, other things in the world could have happened. This is just one thing that happened at that time, is reopening schools. And so there could be other reasons that they had spikes or other reasons that the numbers went down. But I still think it's reassuring to a certain extent that we know that other countries have been able to open their schools with some guidelines and restrictions and spacing and that sort of thing, but they have been able to do that safely. As I'm going to show you, that the attack rate or infection rate for students to other students or student to teacher is very low. So a couple studies that I'll just highlight. I do have these in our references, and these are real cases. Real studies. So Australia, they had in one school or one group of schools, they found 18 positive. So 9 were students, 9 were staff. They went and did contact tracing and found out that they contacted 863 people during those times that they were infectious. And of that, only 2 possible cases were identified. One was likely transmitted by school. So like another adult, by the way, had transmitted it to an adult, but one was unknown. So at the most 2, we're talking a very low percentage of transmission there. In Ireland, they had a large school with 6 people positive, 3 students, 3 staff, exposed to very many other people, so over 1,000. And this was in March, so it was before the masking or other distancing was implemented. So this is just like regular school in Ireland, where they are indoors in March all the time, and only 2 cases were found there. France, and Denmark, similar studies with varied size of the contacts, but very low, well, basically 0 proven cases that came from those positive cases that were in a school. So I have to give you the disclaimer, which hopefully will show up here, but these countries didn't quite have the level of community spread that we do have in the US right now, and we may not find transmission rates in the 1%. We may be seeing 3 to 5% in a school outbreak. That is true, but it's still not 50% or as high as some people might think. So what tools do we have now that we've gone over how this coronavirus gets into our mouth and nose? We have tools to try to protect ourselves, and a lot of essential workers have been using them for a while, including myself. So I just want to talk about what those are. We just need to use what we got. So we have masks, we have physical distancing, and we have hygiene. We don't have a vaccine or a cure yet, but we have these other things. So there are ways, I believe, that we can do it, and I'll just go through each of them individually. The N95 mask is probably a term you never knew until this pandemic, and now everyone seems to know. My lovely Dr. Kathy Garcia is here in this picture wearing full protection, we call it. She has a face shield and an N95 mask, and this is because she is outside in a lower risk setting, by the way, preparing to do coronavirus testing for our clinic. We only wear N95s when we are creating aerosols. So that is performing aerosol generating procedures like a nasopharyngeal swab or suctioning a patient like they do in the hospital. So these masks are not pleasant to wear. They have to be fit tested to be able to be worn appropriately, and they do filter the smallest particles. If you've ever been fit tested, you know they put some noxious smell or gas or something and you put on the mask, and if you can't smell it, then you're good. If you can, then you know there's a leak. So no one needs to wear these in schools, in my opinion. Surgical masks, this is one of our lovely medical assistants modeling a surgical mask that we wear every day in clinic all day long. They're easy to use. They can be universally applied to all ages and sizes. You don't have to fit test. They actually work amazingly well. In influenza studies, there is no difference. In Hong Kong, a big study has been cited, no difference between N95 and surgical masks for healthcare workers in close contact with positive patients, as long as they weren't doing the aerosol generating procedures. So and that would be like school. So you're talking to someone, you're around someone. This does protect you a little bit, but it also protects others from your respiratory droplets. So this is going to be the type of mask, this and cloth masks that you're going to be wearing at schools. So again, we have cloth masks because it's just not reasonable to have disposable surgical masks for everyone. And we'd like to have these reusable type of masks that people can wash, maybe accessorize a little bit. So I will be the first to admit that we do not have ironclad data on masks. There's been a lot of conflict and contention, but really, people, this is what we've got to work with. And it's mandated. So we are wearing them in our clinic. We have for months. And I believe in schools, all adults should be wearing masks. They do filter the larger respiratory droplets, like I told you, are we think the most likely to transmit it. And so I think it's a reasonable request for our schools. It's a little tough to get through, I know. Now, the question about eye protection, I don't believe that I've seen the Jordan School District, which is the school district that I have my children in, have required or recommended any eye protection. Now, theoretically, your eyes could be exposed to droplets and then you could get coronavirus. It's not a common method of transmission, but in the hospital, and you can see a picture of me going to the hospital at Intermountain Medical Center, they do require healthcare workers, regardless of what type of patients you're interacting with, to wear eye protection. In other hospitals, you might be interested to know it's not required. So at the other hospital systems that I work at, we do not use eye protection regularly. We don't have to. In our clinic, I only would wear it if I am with a patient who's actively coughing, sick, or I think that I could be exposed to some respiratory droplets. But in general, I don't think there's anything wrong with a teacher, though, wearing it if in doubt, or having polycarbonate shield glasses or goggles of some sort to protect our eyes from droplets. That may be something that you want to do. And maybe in higher risk settings, I was thinking like band or choir, this could be recommended. Again, I'm not sure how all those recommendations will pan out, but this is another type of protection that's available. Face shields is another option that has the benefit of being able to see your face. In healthcare settings, we do use the mask plus the shield. But again, I don't think this is indicated in schools. There's definitely going to be some people who I think should be wearing shields. I have some really significant concerns about younger children being able to see faces, smiling, how to pronunciate words, how to understand social cues without seeing someone's face. And you have all probably been to a store and you're just like, what? Huh? Because between the mask and the shield, it can be really hard to identify. So I have a couple products here. I don't sell these. I don't really know anything about whether they are 100% proven, but honestly, I mean, we just don't know about any of this. Cloth masks are far from proven. So some sort of face protection must be better than nothing. I thought this Z shield over here was awesome. This is being marketed to teachers and also like restaurant workers and stuff. It kind of comes, it's like a neck thing, and then it flips up and protects all the droplets that would fall downwards. So like for customer service, this is a barista in this picture, I think, or perhaps someone, you know, serving you or cooking at a table. providing customer service. The one here is called the Humanity Shield. It's just a face shield, but kind of with a neck kind of gaiter thing to protect against droplets. That's a great idea. They're not cheap. I think these are 60. These are like 20 something. They do have see-through masks. So our teachers who know their students best and our parents who know their children best may need to request some of these accommodations, I believe, depending on the circumstance. Wearing our masks correctly, I am so sorry that teachers are going to be and parents are given this new job of trying to encourage our children to wear masks. But again, this is a life skill for 2020. And I think if we approach it that way, our children will be receptive. Children just need structure, instruction, education, consequences, and information. And if we tell them that this is what's expected, they will learn. So the Salt Lake County has a campaign, I guess you could call it. They say, cover your face holes. There's some clever ones here about the neck beard, which doesn't help anything, and the under the nose, Pinocchio proud. Everyone knows better than to wear it like that. So some of these funny infographics do help us. Anything that doesn't go below the chin, above the nose, is not working. And so we also need to learn how to don and doff the mask. So I do have a little mask right here. So we would use a technique where you use the ear loops and then put it on like this and then take it off the same way so that you're not touching the front of the mask. One way to help our kids or our adults learn is to tell them that it's like somebody put dog poop on the front of the mask. So we don't want to lay it down on something or touch it or like adjust it like this, when it's on our face. And that means you should also wash hands before and after taking on and off your mask and store it potentially in a brown paper bag or a little slip in their desk or something. So donning and doffing our protective equipment is another life skill we're going to need to teach them. As you may have guessed, wearing masks for children under 10 is controversial, in my opinion. I know that the governor has made a mandate for K all the way through 12, and I think it's quite possible to achieve. I have a picture of my two sons here. One is 6. He happily has been wearing his mask anywhere he needs to, and really with minimal complaint. His older brother and I do it, and so he just knows that that's okay, and he's really done quite well with it, and he's just 6. So if we teach our children that this is expected and that we need to wear masks to protect our friends from our germs, I do think that they will comply in most cases. This modeling by a trusted adult is going to be extremely powerful to engender buy-in. But that said, I think there's going to be a lot of difficult situations that come up in the classroom, distractions, improper wearing of masks, and I would like teachers and parents to take consolation and comfort in the fact that, as I told you, infection rates are very low with children. If children in this younger age group who might struggle with the mask are not very likely to transmit coronavirus to you. And so maybe we can just be a little bit calm and not worry too much, even though we're trying our best to comply. In that same vein, I think many system changes are going to be needed in schools, just like in the rest of our life. There's going to be hand washing stations, cafeterias are going to change. Obviously, there's not going to be self-serve. The cafeteria in the hospital does not look like it did in February at all. And I guess I've sort of gotten used to it, but I miss the salad bar and the Coke machine that So I know cafeteria workers are probably working hard on this. We're going to have to be adjusting a lot of things in schools, and that's not my job exactly, but you can probably see based on the recommendations and the information that I'm providing of why it's important. Larger groups like assemblies might be changed. And again, I know the 6-foot rule is really unimaginable as far as how you could do that in a classroom, even if we have a little bit lower classroom size. But again, take some comfort perhaps in the fact that 3 meters has been shown to be very effective in younger children in other countries, and it is the World Health Organization guidelines. So we're gonna do the best we can, and it will probably not be 6 feet in a classroom. But with these other mitigation strategies, I think it'll be successful. Next, I just remind you that there's so many situations. The special needs children I have seen have suffered so greatly in this pandemic, and they need an individualized approach. For sure, these requirements and these changes are going to be very disruptive and stressful to our children, and the ones that are more vulnerable, the more so. But I really trust that our teachers and our school district officials will be able to find ways to individualize the approach and make it less traumatic for them. So big point here, we just can't have sick kids in school. It is a culture shift that we've had to have in our clinic. So we can't come to work with a cough or a runny nose or any respiratory symptoms. And that's going to be a challenge, but I think it's imperative to have a policy of how to deal with that and a rule that we're not going to get these perfect attendance awards in 2020. So more about that later. Cohorting is a technique that can be used to decrease the contacts that kids have in school, and parents and teachers too, excuse me. Definitely easier to do at the younger grades, but these small and stable cohorts will limit the contacts. Ventilation is key, totally outside of my pay grade, but I would hope that schools are looking at what type of ventilation systems they have, because maximizing ventilation is key for decreasing aerosolized virus. I think I duplicated the classroom spacing thing, and minimizing visitors and other restrictions, like when, if you think of times during the school day where there's traffic jams, like maybe when the school starts and ends, some of those I'm used to saying patients, student flow issues will have to be addressed. So as I mentioned, there needs to be a plan if sick people come to school. That's teachers or children. I don't know what the protocol is. Maybe it's not even set yet, but you parents and you teachers deserve to know and know how to implement that. Parents may be sending their kids to school for childcare because of work situations, because of family health crises or financial or literacy barriers. And in my dream world, we would have a whole lot of social workers that could reach out to these parents who are sending children to school with sick symptoms and try to educate and focus their future choices. But that's going to be a challenge. Again, I don't have the solution to that, but I would just encourage our school districts and our teachers to realize that you should be fairly rigidly, I think, enforcing the no sick symptom kids at school policy. And in doing so, we'll definitely have to liberalize absentee policies or tardies or things like that. Why am I even doing this? Well, the risks of these school closures is so massive. I've been working in primary care clinic in South Jordan since during the whole pandemic, and I have spent almost all of my time dealing with the collateral damage from coronavirus. Closures, not just school, but economic fallout and all sorts of things have been so devastating to our families. I know you all have felt it, and school is just a big safety net and an important part of people's lives that I think is so key. What does the school provide our community? It's a lot more than education, reading, and writing. Many of our children have food insecurity issues. They don't have another place to stay, may not even be supervised when they're at home. Schools are a safety net for all sorts of inequalities and difficulties and injustices and problems that our children suffer. So we need our schools to be open, in my opinion. Young children especially, I have seen suffering, well, all ages. The younger children, because of their social and emotional interaction with other children and their regulation and stuff is so key during like preschool years and first grade. And when they're isolated, they don't get that. And then our teens and young adults are horrifically depressed, anxious, just drowning themselves in social media, and not getting that face-to-face interaction with their peers that they need. So social and emotional development is key. In some cases, our school situation is safer than the home situation. That's sad to think about. We love to think that all of our loving parents could provide all of these things for their children in their home and more, and yet that is absolutely not true. And many of our children, I've been doing these home visits like telemedicine, and I see these parents screaming at their children and living situations that are just really sad. So our children need to be in school to learn things like dance, driver's ed, work-life skills, and the obesity. I've already been seeing it. Like, just you see the growth chart, and then just it's like, oh, quarantine. They are not getting off the couch, and they are eating crap food, and they just are in front of their screens all the time. It's really sad. So I know it's overwhelming to think that you're responsible potentially for all these things. And teachers, it's not just you, it's the whole system. And perhaps we wish we lived in a better world where schools were not a safety net for so many of our society's problems. And that's another discussion for another day. And yet that is, I think, the situation that we're in. And so we have seen the difficulties be more apparent in our children outside of school, excuse me. Again, children may be the least affected by the virus, but they are most affected by the school closures. There's a lot of inequity in our community and in our world. And these school closures just amplify and deepen those disparities even more, because it's those children that are in these lower socioeconomic groups, which are getting hit from all sides by job loss, maybe dying, more pay cuts, more hospitalizations, and then they're out of school. So it's just amplifying, in my mind, the problems. And so that's one reason I believe strongly that we need to reopen our schools and that we can do it safely. Also, an interesting note, women, including myself, have found it extraordinarily difficult to teach children and provide more childcare, and then also still work. So that just makes us have a wider pay gap and unequal work-life balance. Again, our school closures, not to be overly dramatic, but they're potentially actually causing mortality or killing our children. Because this epidemic, like I said, of obesity, depression, anxiety, the parents are so distressed, the children are bored, they're just on electronics. It's been overwhelming to all of us on the front lines. And we need our teachers as partners in this. I mean, it's shown me more than ever how important it is. And so I just want teachers to know how much they make a difference in the children's lives. We know from previous recessions that substance abuse, child abuse, and domestic partner violence increase during recessions. And so all these things truly can cause more harm, I think, than the actual infection with the virus for our children. And so when we're weighing out risk and harm, we need to have really better indices to assess the risks of not opening. I can understand teachers being afraid, and I am afraid for schools to reopen a little bit, but I am way more afraid of schools not reopening and what would happen then. Let's see, not wanting to, so my point being, sorry, teachers are essential workers. They absolutely are. Just like we need our grocery store workers. This is Miss Golding, a kindergarten teacher at Copper Canyon with one of my son's best friends, doing like a graduation gift exchange drive-by thing. I was so impressed by how hard the teachers worked with virtual learning, but I know as well as everyone that many, many people didn't even sign in, and lots of children did not get the opportunity. And those that did or even tried to, it was not the same as in-person learning. So I believe that teachers are essential and that we can protect them, and we should protect them the same that we have protected any other essential workers like grocery store, postal workers, construction, physicians, and all healthcare providers, first responders, policemen. Our teachers are essential workers and they should be treated as such. So a couple ways that we can protect our teachers. We must provide them with personal protective equipment. This should not come out of their salary. I know it's going to be a budget issue, but there should be no exceptions in my mind that teachers and our students should be provided with protection, mask, cleaning supplies, that sort of thing. They must be available and appropriate to the level of risk of the situation. Some teachers are in higher risk groups and they may need to adjust their job. Maybe the highest risk 5th grade teacher should be the one that does the virtual learning for that grade. For example, and really this is nothing different than reopening in every other field months ago, like April, when the Utah plan came out. They specifically detailed what we as employers, some employers, should do with our higher risk workers to decrease their exposures and to give them workplace accommodations that would allow them to be safe. Teachers should be no different than this. Sick policies, of course, need to be readjusted because, like I said, if you cannot come to work sick because you have a cold, you may have more sick days, and that's rough, but that's just the way it is. So we shouldn't be financially docked for that. And testing is key. I can't tell you how revolutionary it would be, and it will be, if we can get our hands on more rapid testing with self-collection. Children can be taught to do anterior and air swab testing, and if we had rapid turnaround and anterior swab testing, it would revolutionize our ability to respond to these type of things. Currently, our 3 to 5 day turnaround with the nasopharyngeal swab hampers our ability to make decisions in a rapid manner. So we need to keep working on that. We've talked about ways to mitigate risk, and I believe we should reopen schools, and I know my school district thankfully has a plan to do that 4 days a week and provide option for in-learning. But what do we do after they open? Because again, this is new and we haven't experienced it before, and we're gonna have plans in place. So definitely there's gonna need to be guidance and education for all parents and staff and students about how to monitor for symptoms, what to do if you have symptoms. There should be quarantine rooms and isolation protocols for positive cases. Just like we monitor our cases in nursing homes at the Salt Lake County and Utah level, I believe there could be school dashboards on the health department website, and then we monitor what's happening in Jordan School District, what's happening in Granite, what's happening in this school, and then our health officials will be able to identify if there needs to be closures or different partial shutdowns or something based on outbreaks if they occur. It's not if, it's just when there is a positive case in a school. We know that, but we can deal with it in ways that we have already patterned in other workplaces to deal with outbreaks. Like, for example, we've had many people either lie or be confused or not tell us that they have symptoms, and then we find out they're coronavirus positive and they were in our clinic. But because we're using universal masking and we're washing and we're just doing all the things to every patient that we see, we haven't had any positive transmission or cases in my clinic at all. And that's significant, I think, because we are on the front lines. So these strategies do work. And as pediatricians, we want to help you with these issues. And the good news is there's just a lot of really smart people in the US and in the world working on this right now. And so Jordan School District or Utah isn't going to have to come up with all these things on their own. There's going to be other smart people to look at and kind of copy from. So in conclusion, I believe that the risks to our students, our children, our economy is much greater to not reopen schools than to reopen. I believe we can do it safely. And it's important to realize and just remember that there is no guarantees in this world, and there's no zero risk scenarios. So every day we accept risk. Every day we accept risk to drive, to go traveling, to see people, to do the things that we do. And school and work is the same. So we just work to mitigate risk, and I think we need to try to be calm that the rest is going to work out somehow. These are my 4 children. I am so grateful when I heard that they could go back to school, and they are delighted to go back to school 4 days a week. We should respect this virus, but we should not live in fear. They have suffered. Our family has suffered. So many people have suffered the collateral damage from coronavirus. So I just hope that parents will take some comfort in knowing that there's a lot of people who really care that are doing everything they can to keep it a safe environment at school. And teachers, I want you to know that I believe you are essential workers and you should be protected as such, and that I think it will work for you. We're not having big outbreaks in Walmarts, believe it or not, or all these other places where essential workers are. And I don't believe that we will have significant outbreaks in our schools, or and I do, at least I should say that I believe that whatever cases we have will be dealt with, and the risks of staying closed or having virtual learning with no other options is much greater than the risks of opening. So we just have to kind of monitor, act on faith, and then adjust as needed, see what happens. As a parent, we need our teachers, and as a pediatrician, I'm telling you, we need our teachers. So we really appreciate partnering with you and hope that you can feel reassured by watching this presentation. And if you have additional questions, I have references here. I know if you're watching this on video, you can't really click on those links, but hopefully I can spread it in another way that people can maybe Google for those resources or find them. And finally, just sorry, if any of you have questions, I've included my email through my work, my Twitter handle, and how to get a hold of me on LinkedIn. I appreciate all of the doctors that I work with at my clinic at Copperview Medical Center for supporting me and for working on the front lines with me. We talked last week about how every single patient was asking us about school reopenings, every single patient, parent, patient who has a school-age child. And so we wanted to address this both to parents and also teachers. And also Bryce Dunford, the president of Jordan School District in Utah. I appreciate him being very willing to listen and asking me to do this presentation. And let's hope I can end this correctly. And thank you again for your time.